James is calling me then. Super.
Hello.
Hello? Hey. Hey, James. Yeah, okay. Okay, not a problem. I'll just let him know. Yeah, okay.
Good morning, guys. Can you see my screen? Can you hear me?
Okay, I'll just let him know that. Okay. Okay. Thanks, James. Okay, bye. એ કહે છે કે એ અટેન્ડીના જેમ આવેલો છે એને કહું બસ ચાલુ કરી કાઢે સ્લાઇડની ના ભરી કાઢે નહીં દેખાતું ચાલુ કરી કાઢું સંવાદ બે થઈ ગયું.
Okay, perfect. So, all right, guys. So welcome to the webinar. I'm pretty confident that you all can hear you. You all can hear me. And good morning to everyone back in India. And hope you all are staying safe, staying indoors, and preventing the health crisis and managing as well as you can. So I'm going to start by introducing myself today. Now, just a few housekeeping rules. If you have any questions, please feel free ask them in the comment section by the side. And as and when we get to it, as and when I get to it towards the end of it, I will try and answer all your questions. So what are we going to talk for the next 1 hour today is about the conservative management of a complete ACL tear. Now, I chose to talk about this for many reasons, which I will come to. And I think already Dr. Divya has already spoken to you guys about it and about who I am and what I do. But I'll still like to give you guys a little bit of an introduction about myself. So my name is MUSTUFA KAGDI. I'm an APA titled Musculoskeletal Physiotherapist. And I am an APA titled Exercise and Sports Physiotherapist. I am a clinical mentor at the Back in Motion Health Group. I am a clinical educator at the University of South Australia and Flinders University here in Adelaide. I'm also an affiliate lecturer with the School of Medicine at the University of Adelaide. I am a clinical mentor with the private group called The Second Visit, and we are based here in Australia, in Adelaide. And I'm also the co-founder and presenter at the Skills for Physios Learning Academy. So this is just a little bit about myself. And now we're going to talk about a little bit about the ACL injuries. So all of you are very clear and you guys know what the ACL stands for, which is the anterior cruciate ligament. Now, there are many restraints within the knee joint for the anterior translation of the tibia, but the ACL provides around 90% of that stability. Now, less known is that the ACL also prevents a little bit of the rotation of the tibia on the femur. Now, the ACL is divided into two bundles. The first is called the anterior medial bundle, and the next one is the posterior lateral bundle. Now, the anterior medial bundle is under significant tension between 30 and 130 degrees of knee flexion, so that's when it's active. And the posterior lateral bundle is quite under tension when your knee is fully extended. Now, the posterior lateral bundle also controls the tibial rotation. Not so much the work of the anterior medial bundle, but more so the posterior lateral bundle. Okay. Now, the ACL injuries, research has shown that are much more common in females than in males. The most common mode of injury is change of direction, or when the weight is going through the single leg. Now, the patient usually describes that these complete tears are extremely painful. And the best time to check these injuries is within the first hour of it actually being done. Okay? Now, in terms of ACL injuries, there are many sports that are quite commonly injured with the ACL. Any sort of running sports, footy, basketball, netball, there are many sports that get these injuries, but they're very common within the running population. Okay. Now, moving on. So once your patient has ACL injury, there are basically two stages or two methods that we can approach. The first one is that we go the surgical route, and that involves a surgical intervention under arthroscopy done by a qualified surgeon. They reconstruct the ligaments, and then the physio's job is to rehabilitate the patient with the appropriate exercises, keeping in mind all the other the phases of rehabilitation. Also, if it is a planned surgery and not an emergency surgery, we can also do what we call as prehab or prehabilitation, which is preparing the athlete or the person for a ACL reconstruction. And the end goal is to basically get back to return to sport, or in this case, return to pre-injury activity levels. Okay? Now, the next one that we can do is conservative management, and conservative management will have your phases from reduction of swelling to reduction of pain to increasing range of motion, strength, balance, proprioception, right through till the end, which is your sport specific training. All right, guys. Now, there are a few considerations that need to be taken into account whether we decide when a athlete or a patient needs to undergo operative surgery. Okay, this has to be done in conjunction or in discussion with your patient as well as the surgeon. All right, so the first big one that you need to consider is age. So people in between the 20 and 40 seem to respond really well to the operative management. Next is the degree of instability that we can see. So the degree of instability, so more unstable, the better the chances are that the surgical option will provide a better outcome. We also have to look at whether there are other structures involved, such as, or the degree of the involvement of the other structures, such as your meniscus and your collateral ligaments. So the more structures involved, the better is the operative outcome. Always take into consideration the patient's opinion or what they want to do. What is their target in terms of returning back to sport or pre-injury activity? Also, the occupation of the patient plays a big part in deciding whether you have a reconstruction or not. Certain occupations, you want them to be reconstructed quicker so that they can go back to work quicker. Also, the type of graft needs to be decided, whether it's a patellar tendon graft, whether it's a hamstring graft, whether it's an allograft, or whether it's a single or a double bundle. Now, the reason why you have to talk about the single or the double bundle is because I've already told you that the ACL has the anterior medial and the posterior lateral bundle. Okay, so the double bundle seems to work a lot better. Also, the timing of the surgery is the key, how quickly or how soon or how late you want to do it. And also, we are looking at the potential side effects. So one of the big potential side effects of a ACL reconstruction is that the graft gets scarred and gets tight, and then you have lots of range of motion restriction that can happen. All right. So as I said, just putting your hand up now. If you have any questions, feel free to ask me right at the end. I will give you certain time and I will try and answer the questions as well a bit later. Okay. Now, what are the considerations when we go for conservative management of your ACL? So definitely we are looking at the age, and conservative management seems to work a lot better for your younger population. Also, the instability, it doesn't happen all that often, but pure isolated ACL injuries will respond way better to conservative management. Also, if there are other like collateral and meniscus injury is there, as long as they're minor grades, conservative seems to work a lot better, and that's what it's talking about the other structures. Definitely taking into consideration whether the patient wants to undergo the ACL recon, purely because they might have had past experience or experience of other friends or relatives that they might want to consider as well. Also find out what is the target for return to sport. Have they done the injury early in the season? Is it middle of the season? Is it late in the season? Can they go back to the normal season? All of that. Plus, if it's a professional athlete, that needs to be taken into consideration, or they're a recreational athlete, we need to consider that as well. All right. So it's fine for me to say that we should do conservative or we should do surgical, but interestingly, what does research tell us? And this is very important. So, and as you can see, in the last 4 or 5 years, there has been a lot of systematic reviews of literature being done. For example, Newsom in 2017 says, and is a direct quote, that the authors of this systematic review found no difference between surgery and conservative treatment in the patient-reported outcomes of knee function at 2 years and 5 years in the young active adults treated for acute ACL. Okay, what does this mean? That after 2 years or 5 years after the injury, in terms of how the patient feels, there is no difference in the outcomes between surgery and conservative. I mean, look at the other systematic review done in 2016, a year before, by Monk et al., and they found the exact same thing, that at 2 and 5 years follow-up post the ACL injury, there is no difference whether the patients underwent surgical or conservative management. Okay, a bit closer, Krauss et al. In 2018 said that it cannot be definitely concluded whether surgery or conservative management of ACL leads to a better function outcome, which means whether you go surgery or whether you go conservative, there doesn't seem to be a lot of difference. So what this tells us, that research is telling us that you can go either way, but you have to satisfy these criteria that we see in terms of the ACL operative and the ACL conservative approach. All right. Now, so this brings me to this very, very interesting case that I have been treating for the last few months, actually, and I want to talk about her to you. Now, please be assured that I have taken prior permission from the patient to share the details, and she's happy for me to share the details, as long as obviously we cannot identify the case or the patient in any way. So I have full consent to share her medical information with all of you. So let's talk about the subjective findings of this case. Okay, so obviously she is a female. She is 19 years old and plays netball. Okay, now for the people who don't know what netball actually is, netball is a sport like basketball, and the only big difference between the two is that that in the air, when you're doing the playing netball, you cannot bounce the ball, so you cannot dribble the ball. So if you hold the ball, you have to suddenly stop. The moment you hold the ball, you have to stop. In basketball, when you hold the ball, if you are dribbling, you can actually continue to walk or run. But in netball, The moment you get the ball to you, you have to stop. So you can understand that that sudden stopping, change of direction, jumping, landing in a netball can definitely puts a lot more stress onto the knee and the ankle joints. Okay, so knee and ankle injury is very common in netball. It's a predominantly female sport, so only females tend to play the sport. However, there are mixed leagues with men and women both playing this sport. Okay, so how did she do it? She got the ball and she was trying to dodge a player and she went sideways. So her knee twisted, went forward, and she immediately felt it go, like a little bit of a pop in through the knee. When did this happen? Was towards the end of February this year, 2020. Okay. Now, because it was the first time ever she did this injury, she went to the doctor, into the hospital, emergency. So they did an MRI and they found a complete tear of the ACL, and there was a lot of swelling in the knee, obviously. So the surgeon said that in a couple of weeks, once the swelling goes down, they wanted to operate. However, because of COVID-19, there was a lockdown of elective surgery in Australia. So non-life-threatening surgeries were all cancelled with immediate effect because of the lockdown. So for 1 month, she did not know what to do. So she presented to me 1 month after the initial injury. And she had not done any exercises. She had not done any sort of rehab. She was just basically putting ice on it and had stopped playing netball. Also, netball stopped because of the social restrictions and the lockdown in Australia. Okay. So when I spoke to her, she wanted to go back to sport as quickly as she could. However, with the suspension of the league, the netball league, that wasn't a problem. Her biggest concern when she saw me was whether she should have the surgery or whether she should not have the surgery. Now, this is very, very common case. It's a very common scenario. Very young patient comes to, and they're not very sure what they want to do in terms of should I go for surgery or should I do the conservative and see how it goes, blah blah blah, all of that. Okay. Now, general health, she was fine. She had not injured herself before, like ACL or any other ligament injuries. She did have a past history of frequent rolling, ankle sprains, ATFL mostly. Yeah, apart from that, she was not on any medication. She had not taken any steroids for the last 6 months for any reason. And she had never been on blood thinners. She didn't have any symptoms anywhere else. No pins and needles, numbness, no radiating pain, nothing. Okay, so she was, apart from this injury, really, she was fine. Okay. Now, when we move on to the physical findings, okay, now this is very important. So when I observed her, there was a little bit of swelling around the affected knee. Not too much. There was no bruising. Maybe a couple of centimeters different when I checked for the circumference around the knee, but nothing major. Given the fact that this was 1 month after the injury, that is not unsurprising. Okay, so the swelling does reduce by then. So in terms of her knee active range, actively she could get to around 100 degrees of knee flexion, and then it was hurting. Knee passive range of motion, which is a PROM, was also very similar and limited by pain. I also thought that there was a lot of apprehension, what we call as fear avoidance. Okay. Her ankle range of motion was full. Her hip range of motion was full. When she was walking, she was not feeling any pain, and she did not feel that her knee was giving way. Okay, now this is very important. She did not complain of feeling unstable in the knee. Okay, now as you all know, the two major tests that we do for your ACL is your Rockman's and your drawers test and your anterior drawers test. or your posterior draws test, the draws, okay? So the lockments, you all know how to do the lockments. It's very easy. I have a video that is coming up and you will see and hear it as well. So we'll do that. Now, the good thing is that there is a research come out very recently, and I can later on I'll share give you the reference list on the group as well so that you can follow it up, is that they compared whether clinical diagnostic tests such as the Lockmans and the Drawers test, how good are they when compared to MRIs to pick up ACL injuries? Okay. Now, surprise, surprise, clinical tests are as good and in some cases better in picking up ACL complete tears than an MRI. Okay. So guys, trust your clinical skills, trust your testing, keep practicing till you get better and you can quite clearly pick up. So when you do a Lockman's test, it is as good as doing an MRI to pick up a complete tear of the ACL. Okay, that is really cool to know for us as physios that we can actually do this and have really good evidence and very confidently say whether it's a complete ACL or not. Okay, ACL tear or not. Now, she could do a squat, not too painful, maybe a little bit of discomfort. Okay, she never complained of pain. This is the best part. She never complained that it was painful. She said it was more squat was a bit uncomfortable. Okay, and when I got her to stand on the unstable leg, her balance on proprioception was very much affected, which kind of makes sense. So if the ACL is injured, you've got proprioceptors in the ACL, and that can obviously affect the way the stability of the lower limb comes in. All right. Now, so far, what do we know? I have told you what the subjective information is. I have told you what the physical assessment is. I've told you what the age and nothing, no other injuries, right? But I actually haven't told you which knee it is. Now, I've done that on purpose because when you actually see the videos, I want you to look at the videos and tell me if you can pick up which knee it actually is, okay? Make sure you write in the comments which knee you think it is, and so that everyone can actually see it as well, and we can discuss. Now, there's a very specific reason why I haven't done it, and you will find that out in a second, okay? So now, moving on to the next slide, which is active knee extension in high sitting position. So have a look. Okay, I'll play the video. Hopefully you can hear it. So turn the volume up a little bit. You'll hear me talk as well. Turn up the volume, listen to the video, look at the movement, and I'll give you a couple of minutes. I want all of you to write in the comments which knee you think it is actually. Okay, you ready? Here goes. Okay, we're playing the video now. Turn up your volumes. You'll hear me speak. Yeah. So what I'll get you to do now is just kind of straighten your right knee for me. Does that hurt anywhere?
No.
Good. And now the left. Does that hurt anywhere? Good. And how does that feel?
Like a little tight in the calf. But
Yeah.
That's not my knee. So.
Okay. Let's. All right, guys. You've seen it. You've seen active knee extension in high sitting position for my patient. Now I'm going to play it again for you, and then I'm going to give you 1 minute to actually write in the comments which knee do you think it is. Ready? Here goes. Yeah. So what I'll get you to do now is just kind of straighten your right knee for me. Does that hurt anywhere?
No.
Good. And now the left. Does that hurt anywhere? Good. And how does that feel?
Like a little tight in the calf. But
Yeah.
That's not my knee. So.
Okay. Let's. All right, guys. I'm going to pause here for a minute, and I want you guys to write in the comments which knee you think it is. Okay? All right. So looks like a lot of you have made some comments. I'm going to have a look at them now. So I'm going to pause the PowerPoint for a second. Okay. So you'll see my screen. Okay. So good. What do we have here? So right knee, left, right, 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 left, 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 right, left, right, left, 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 right, right. Okay, so there's a mixture. Okay, so that's excellent. There is definitely a mixture of right and left. Let's see if I now show you the next slide where I'm actually doing the lockments, and then you will know whether it is the right or the left knee. Okay, this is very easy. Have a look at me doing the lockments now. Okay, and you can hear me as well. All right, so we have a look at your knee. We'll do the test again. So just nice and easy. Try and relax the body. That's nice. Sorry guys, we'll play it again. So we have a look at your knee. We'll do the test again. So just nice and easy. Try and relax the body. That's nice. Still relaxing. That's good. Just try and relax. Okay, that's not bad. So those ligaments are feeling quite good. Yeah. All right, guys. People who said left, well done. The left is the complete tear of the ACL. Okay. As you can see in that video, there is no end feel, and you can see towards the end of the video, I also quickly check for the lateral collateral and the medial collateral ligament. Okay. But those who said left, I'm going to give you a bit of a congratulations and well done for picking up it's the left. And those who said right, well, that's okay. If you saw her just like this, you wouldn't know whether it's the right or the left. Okay. Now, this is the patient as she is walking. All right. So have a look and tell me what you think. Is there any problem in the gait? Have a look. Yeah, and then walk back. Alright guys, we'll do it again. Yeah, and then walk back. So guys, remember the videos that I'm showing you of her walking, and the next one is after rehab, since when she's seen me end of March. Okay, end of March and April. So this is 2 months worth of rehab with her, and a total of 3 months, which is 12 weeks from injury and 8 weeks since starting physiotherapy. Okay, so the next video is her running on an ACL deficient knee 12 weeks post injury. Okay, keep that in mind. This is 12 weeks post injury on an ACL deficient knee. And go back again. And towards me. Alright guys, watch it again. And go back again. and towards me. All right, guys. It's very, very interesting that after 8 weeks of physiotherapy and exercises, this young patient of mine, 19-year-old female who plays sport, is actually jogging on tarmac without feeling unstable or any pain, no discomfort, feeling rock solid. Now, I didn't get the videos because I was actually passing the ball with her and mimicking her netball throws and catches and landing and jumping. But she could do all of that without pain. The only thing that was stopping her was her fitness was down because she hadn't played for 2 months. Okay? Now, I'm going to show you her standing on a Bosu ball. Okay, so we did a lot of stability work. So this is my patient with her eyes closed. Okay, have a look at the video.
Keep your eyes closed. Well done.
Okay, so watch it again.
Keep your eyes closed. Well done.
Okay, my instructions were that she has to equally go and put weight on the right and the left as she's doing that. Okay, now this is squatting on an unstable surface just to see how stable that ligament or the knee is feeling. Have a look.
Yeah. Come in.
Good. One more time.
Excellent. There's no wobbling, there's no pain, there's no discomfort, there's excellent control on the knee. Have a look at the next one. This will surprise you. Okay, ready?
Okay, go for it. Try that again.
Now, that's the first one. It's a bit dodgy, but let's try that one again.
Okay, go for it. Try that again.
Going too much good at you.
That's okay. Try that again.
So,
Much better. Let's try it one more time. Good.
start on that.
Gonna go a bit further back. Now try that. Yeah.
Yeah, perfect. When you are.
Good. Try that one more time. Good.
Alright, guys. Have a look at this one now. So she's standing on the unstable
Let's keep
surface
your
with
eyes
her
open,
eyes,
yeah?
Yeah.
and now she's
Now,
going to
can I
close
get
her
you to
eyes.
close your eyes? Much better when you think about it.
Okay, now just let me know if any of you want to watch any of these videos again. I'm just going to log in and have a look at your comments. So just let me know if you want to have a look at that again. Okay, so let's move on and crack on towards the treatment side of things. Okay, so just remember, I've already told you that she's had a lot of ankle injuries in the past as well on both sides, so that will complicate it will complicate rehab a little bit, so we had to focus on ankle exercises as well. We also know for a fact that every time you have a lower limb injury and your walking gets affected, you will have inhibition through your hip abductors or your gluteus medius minimus muscles. So we have to work on that as well. Now, just remember, ACLs cannot be rehabbed purely by themselves, okay? You have to look at all the other factors within the lower limb, because the lower limbs work as a closed kinetic chain, okay? So one joint affects the other. So you cannot treat the knee in isolation, you cannot treat the foot in isolation, you cannot treat the hip in isolation. It has to be all connected. So I've also seen a couple of comments and you guys think that there is a little bit of weight shifting. Think about it. A complete ACL tear in 8 weeks, that is acceptable, okay? They're going to have a little bit of weight shifting, which is expected and accepted as normal after only 3 months, okay? So the tissue healing has to still occur. You can't ignore that fact. So this girl has made tremendous improvements with her knee, okay? Now, so I told you first that my focus was that she was very scared, she had fear avoidance. So we had to try and tell her that yes, she has an ACL deficient knee, but she's walking, she's not in a lot of pain, she can do everything else. She was driving a car as well, no problems, okay? So the big thing for us was to improve her range of motion, okay? Just to give you perspective, after 8 weeks of physio, she can now sit on the floor cross-legged and play with her sister's children as well. So her nieces and nephews, she can actually sit down on the floor and get off on the floor without a problem, okay? Next thing that we had to work on was improve her confidence. Her confidence in terms of how she thinks her knee is going to get better, okay? Also, we started working on strength. We started off with basic mini squats and we've progressed to, as you can see, lots of jumping and plyometric exercises as well. She did a lot of TheraBand exercises, she did a lot of glute strengthening work, she did a lot of balance and proprioceptive training as well, and that has really helped her come along quite nicely. And the last thing that we've started when I saw her last week was functional training for her return to sport. Thankfully, Australia started easing the restrictions, and now indoor sport can start taking place and training and competition can start in the next few weeks. So she wants to get back. So we actually started sport-specific training as well. Now, there must be some of you who've actually treated ACL reconstruction, so ACLRs as they're called, anterior cruciate ligament reconstructions. Now, the phase 1, phase 2, phase 3, phase 4 is usually return to sport. Now, phase 1 or phase 2, phase 1 goes on for the first 2 weeks after surgery. And what we are trying to do is get around 100 degrees of range of motion, reduce swelling and start improving strength of the quadriceps. Okay. We cannot do anything functional or sport related activity in the first 2 weeks. Now, phase 2, where the goal is to totally eradicate swelling, get full extension in the knee, and the knee flexion needs to be beyond 130 degrees. These I'm talking of phases after surgery, okay? Don't get me wrong, this is after surgery. So phase 1, first 2 weeks, you take care. Reduce the swelling, that's it. Phase 2, there should be no swelling, there should be 130 degrees of flexion and full extension. And phase 2 is lasting for 12 weeks. Even at the end of phase 2, there is no sports specific training. All you can then start doing is start walking without the brace, and they can get onto something like a stationary bike just to help improve the movement, maintain the movement and improve the strength of the muscles, okay? Phase 3 is from 3 months to 6 months, okay? Where you have to continue to improve the strength, continue to improve the power, okay? And we start doing return to sports drills, okay? this is the time. So around 6 months, by the end of 6 months after rehab, after surgery, they should be able to start jogging in a straight line. Okay, straight line running can only be started after 3 months after surgery. Okay, they can go only in straight line, so they can run forward, backward, they can run side, but no change of direction. And phase 4, which is around 6 to 12 months, okay, after injury, that is when they start returning or thinking of going back to sport. Most cases of ACL reconstructions, they go back to return to sport 1 year after. Okay, with my young patient with conservative management, we are thinking of getting her back to sport within 6 months. So we've halved the time, and there are a couple of really good Australian physios making huge improvements and talking a lot about conservative management for ACL reconstructions, even in elite sports people. Okay, a couple of great researchers, great physios, and you can obviously look their work up. But yeah, okay. So compared to where surgery is, so if she had undergone the surgery, at the moment she would still be in phase 2. So we'd only be getting her to walking without a brace. But at the moment, we are thinking of phase 4. So this is a really good case, very good outcome for my young patient. All right. Now, in conclusion, what do I want to tell you about is conservative treatment for ACL tear is actually a very good option. Okay, very good option, especially for your young patients who are not playing elite sports. Okay, especially because they don't have that kind of extreme demand on their joints and on their ligaments to keep stable. Okay, second, younger patients, their sporting activities and how unstable they are in a daily life is a big consideration on whether you want to go conservative or surgical. Now think about this. If my patient, every time she got up or she was walking a few steps and she said, oh, my knee is giving way or I'm feeling very unstable, then maybe conservative is not the way to go because the instability is too much. Okay, but in her case, she was doing a lot of things. So plus the restrictions from COVID-19 didn't, there was no way the surgery could have happened till now, really. But she's already so far ahead with her exercise and her rehab. She's not even considering having surgery anymore. The other big thing that I want you to definitely remember is that we need to have a structured and a timely exercise program if you want to improve outcome. What this means is that in your head as the treating clinician, you need to know when is it right, when can I improve the strength, when can I push the patient, how much exercises, how much intensity, how much frequency. Okay, you need to decide that as a clinician with discussion with the patient. Okay, in discussion with the patient, you need to decide how much are you going to push, when do you start exercising, how much do you start exercising, when do you start all of that. Okay, you have to have a clear, very clear plan in your mind. Okay, what I would definitely recommend at the end is please consider conservative management for ACL tears. There's a couple of really good papers. One most recently in 2010. There's another one that's a systematic review looked at what sort of stability exercises are really good, and what they found is that there is some really good evidence and return to sports almost on par with surgical management as well. So I'll definitely consider. The other thing is, as I said, do you remember I told you that we also consider the timing of the surgery? Do you remember that? It's like, I was like, oh, what was the surgery? The timing of the surgery. So, in terms of ACL reconstruction, there's always been some evidence that delaying surgery will help in reducing the risk of stiffness in the joint. So, you know, your arthropfibrosis, like soft tissue stiffness, basically in through the joint, that risk gets reduced quite a lot. Now, there is a couple of studies that actually suggest that ACL recon should be delayed by up to 3 weeks after injury to help the swelling settle down and regain some sort of movement and pain management. Okay. So there's a couple of other systematic reviews that were inconclusive as well. So they're like, oh, you do it early, you do it late. It doesn't matter in terms of overall outcome. But there is a growing body of evidence to suggest that delaying ACL recons for a few weeks after the initial injury actually helps the rehab process. So if the patient is reducing or delaying the surgery anyways, I think it makes sense to do all of these exercises as prehab, explain to the patient as a physio and tell them what to expect. Why are we doing this? Strengthen the muscles so that after surgery, the swelling is less and the strength gains are faster. Okay. So irrespective of whether you go ahead with a complete conservative management of the ACL, just doing prehab might be a really good option as well. So what I'm trying to tell you is, irrespective of whether your patient is going to have a surgery or not have the surgery, exercises are really important. All right. Now, I am going to lay aside a few minutes to answer your questions that you will post for me. So don't worry about that. Please join us on the second visit. So you can go onto Facebook. It's a closed group and you can join us on the second visit. It's just exactly like the current group that you guys are on. It's only for physios. There are some questions that you need to answer before you're granted access. We post videos almost every day on how to become better clinicians and how you can make yourself better to give better outcomes to your patient. So if that is something that you want to do and you're passionate about, please join us on this second visit. Also, you can definitely look us up on Skills for Physios. It's skillsforphysios.com.au. James and I, we do regularly come to India, and we've got a couple of other really great clinicians who come and run 2-day workshops in India. Unfortunately, at the moment, because of all the travel restrictions, that may be delayed. But we have been doing this since 2017. So we've been doing this for a while, and we've got some excellent responses from young physios and even experienced clinicians. So please look us up on the second visit on Facebook. Look us up on skillsforphysios.com.au as well. And we are on Facebook. We are on LinkedIn. You can contact us by email. And you can definitely message us on the Facebook group as well. Yeah, so what I'm going to do now is I'm going to cut to the screen and I'm going to have a look at your comments and your questions. And once again, thank you so much for waking up very early on a Sunday morning in India at 10 o'clock. And I definitely want to thank everyone on including Dr. Prem, Dr. Divya, and all the great clinicians who are on the Academy of Physiotherapy case study group. They're really doing a good job. They're a bunch of young physios and they really need your support to get going. And thank you, Prem, for getting in touch with me and organizing this. Really appreciate it. All right, guys, I'm having a look at your questions and I'll answer them as I see them. So guys, some really good questions coming through. So I'm going to try and answer as many as I can. Now, let's have a look. Where did that go? Okay, so first question by Kishan Sahu says, when should my patient go for walking without braces? Now, I'm assuming that this patient has undergone surgery, and if they are undergone surgery, basically you got to listen to the advice given to the surgeon, by the surgeon to you in terms of their rehab, but mostly by phase 2, okay, which is by the end of phase 2 they should have started walking without the brace. But also when you're getting the patient to walk without a brace, remember you have to make sure and tell them that the ligament is stable, if nothing's going to happen to it. Okay, you just got to make sure that you talk to your patient very well before you do it. But by the 3 months mark, you should be able to get your patient to walk without a brace. Okay. Now, next question by Madhuri, Madhuri. Now you're saying that this patient came to me because of the lockdown, there was no surgery. But if she came to me when she did the surgery, would my treatment plan would have been very different? I don't think so. I would have given her, I would have tried to improve her range of motion. I would try to improve her strength. And if she was feeling stable, then my recommendation would have been same, because she does fulfill a lot of the criteria to not go for a surgical management. Okay, so age was the big one, because there's lots of research to suggest that younger patients recover better with conservative management. Which brings me to the next question by Mary Victor. The indication for ACL to be operated. For the ACL to be operated, it has to be a complete tear, which is the first one. It has to have other major tissues damage, plus the patient has to be in a lot of pain, and the patient wants to go back to sport quicker. Also, the big one is that they've had past experiences and they've had a really good outcome. So there's strong evidence to suggest that if someone has a good outcome with one recon of the left knee, they will have really good outcome with the right knee as well. So the indications are patient driven as well as anatomy driven. Now, there is one more question that I definitely want to answer. Where did it go? So by Rakhu Das, I'm assuming it's a question. It says duration of conservative management. Basically, if you know anything about sports specific rehab, they need to be able to complete 2 training sessions at 100% intensity without any discomfort, instability, pain, and then they can go back. So then your conservative management goes more sort of into a maintenance. Okay. Now we are there with Mansi Jain. So yes, if there is a medial meniscus injury, which is quite common after an ACL, and also a collateral ligament, depends on the grades of the ligament. Okay. If they're higher end, then you're looking at a lot more hard work, and they might end up choosing ACL reconstruction, which is not a bad thing, because you can still continue to rehab them after as well. Now, Ali Raza Baluch, we have a question: how do we improve quadricep tightness, and what if the patient comes after surgery having a problem in squats, having pain and scarring? So post-surgical complications with ACLs need to be referred back to the surgeon as soon as possible, because then they would want to review their surgery and they may choose to do other options, which I'm not an expert at. It's the orthopedic surgeon's field, so they know a lot more than I do. But in terms of quadricep tightness, tightness will only develop if the range of motion is limited and if you don't regain the range of motion. So if the range of motion is full and you have reasonable flexion, you can initiate dynamic stretching through the quadriceps as well. Side lying will do the trick. Just standing with the leg on the chair will do the trick as well. Okay. Now, Mary, you've got another question for me, which is a time limit when it should be operated. There's no such thing. Even after a year of conservative treatment, if someone feels that the knee is still feeling unstable, they go ahead and have the surgery. So there's no time limit as such. Sanjay Das, conservative or surgery? It depends on the patient, and it depends on the given circumstances of the individual patient. So one is not better than the other. That's what I've found. And how much of literature I've been reading, I'm finding the same thing. I'm not finding big differences there as well. Now, Ashish Rana, yes, tissue healing timeframes depend on the age of the patient, the fitness level of the patient, smoking, alcohol, other comorbid factors. However, if there is a partial tear, return to sport needs to follow the same sort of guidelines. So gradual loading. If the pain's gone today, doesn't mean healing has happened. So return to sport will take time. Okay, so you're looking roughly at around anywhere between 8 to 16 weeks before. Okay. Now, Hunain Zaki, the type of graft. So you have the patella tendon, you have the hamstring tendon, you have the allograft, you got the double, you got the single. So there's many different types of grafts. I have, for this webinar, I'm actually not going to talk about one graft versus other. And I again believe that some of the orthopedic surgeons are much better at talking about those than I am. Now, in case of post ACL in terms of surgery, or I'm answering this question by Sumi Saha. This is any exercise in particular harmful. So you always want to try and limit the open chain exercises even after surgery. So you do the same after injury, and you just want to see if they're stable or not, because remember, it's an anterior translation, and it's how the extent and the way it has torn. So yes, always be careful, but I'm always guided by the patient's pain and if they've had surgery by the surgeon. Yes, yeah, ACL is definitely, well, amongst the injuries, the ACL is a lot more common than the PCL. I'm just answering Rohit Maz's question. We find that the hamstring graft has a much lower rate of rejection and contraction. So the hamstring grafts are used a lot more these days. Thank you, Tanya Gujral, for that question. Dr. Kunal Panchal, it's a good question. I haven't come across any change in rehab, except that you want to, if it's a hamstring graft from the other leg, then you want to rehab the other leg as well. But most commonly, we find that it's taken from the same leg. So, very good question by Kishan Sahu. How do we know that the ligament is stable clinically? Well, on ligament testing, if it's an ACL deficient knee, and if you check it after 3 months, it's still going to be lax on the Lockman stress. That is a structural thing. But clinically, if you want to look at stability, you have to look at how they perform in terms of function. If they are feeling fine in terms of function, they are clinically stable. Hetal Tucker, really good question. Here in Australia, there is no evidence to use any sort of modalities, electrotherapeutic. If we do, it's against evidence and considered illegal. So we actually don't really use a lot of modalities. Now, Kilti Furia, that's a good question if you have other comorbid factors. And this is when we boil down to what I was talking about, the instability. The higher instability, the better it is that they go for surgery. Ashka Bodade. If there's an avulsion fracture, it's always better to go ahead with and have a surgical opinion. And in terms of later stages OA, look, conservative or surgical, the incidence of OA doesn't change a lot. Well, Humaira Alam, there are not many contradictions for conservative treatment unless and until there is a lot of pain and there's a lot of instability in the knee. Unsure, I think was a good question. Why is the ACL more common in men and then in women? Could be genetic factors, could be a predominant increased, more flexibility. There's many reasons. So, Sakshi Kalia, if there is a lot of pain in the knee, what management is a lot of pain relieving techniques, taping can be done, isometric exercises can be done. It's really good. So after reconstruction, anywhere between 6 and 12 months is the return to sport. Samina Qureshi, thank you for that question. Rakudas, difference between ACL and PCL. There's a big difference. The ACL is translation anteriorly, the PC is posteriorly. So yeah, they restrict different things, so they'll present differently as well. Dr. Krishna Bijay Agrawal, good question. I will always try conservative first. As I said, we need to delay surgery for 3 weeks at least to have good outcomes. So in that 3 weeks, we'll know. Sumi Saha, if there's a fixed flexion deformity, they need a surgical review. Don't try and treat that. Suman Lata, conservative management healing is going to happen irrespective of whether you do anything about it or not. That's just the body's mechanism. How it heals, that's different, okay? And an ACL deficient knee will always stay deficient if there is no stability provided externally. So on testing, you'll always find it, but yes, the healing is functional healing that you're looking for. Where Andre Sudarsa, if the patient is elderly, can you define what elderly is? Because if you mean like about 65, I'd be surprised if they had an ACL tear. But they can if they're exercising. If they are fit and healthy and have no other comorbid factors, the age is not a barrier for conservative management or exercises. Omkar Mulik, I don't know if it's a comment or a question. So if there's a full thickness ACL tear, you want to make sure that the instability is not that bad. Dharam, I'm answering your question. So just make sure that the instability is not too much and there's not the other factors are not too bad in terms of the grade of the injuries, okay? Treatment can start with pain relieving techniques and work up to exercises. Sarjan Modi, great question. I personally find that balance and proprioceptive exercises work a lot better with bare feet. That's personally, and you would have seen in my videos, my patient didn't wear shoes. Mansi Jain, good question. Obesity seems to be a contributing factor for many other things, including carrying excessive weight, which is more joint reaction forces. So that kind of makes sense. Now, in terms of diets, Ali Raza Baluch, I'm not quite sure, but I would say just eat healthy, eat clean, avoid processed foods, and if there's any particular dietary requirements, I'd actually refer them on to a nutritionist. If there is a lot of instability in terms of functional instability, Humaira, I would definitely recommend that they have a surgical review. So one of the last questions I'm going to answer is, Mary, is there any grade for instability? The grades of, if there is, you go by when you do a test, you are checking for what we call as end feel. If there is no end feel, it is a complete tear, so that's the most unstable. If there is laxity but an end feel, it's grade 2. If there is end feel and minimal laxity, then there's a grade 1. All right. Last one, definite last one by Dr. Kunal Panchal. What reform should be achieved first, full flexion or extension? Doesn't matter. Keep the knee moving. Okay? Keep the knee moving. is it common with OA without injury? I'm not quite sure what your question means here, Mary. So what I'm going to do now is I'm going to thank all of you once again. And yes, I will forward the links of all the things that I've spoken about to Dr. Prem, because I've been in touch with Prem for a long time. So yeah, we'll talk later, and thank you so much, guys. Thank you.